Good afternoon. Okay. Can you see the presentation? Now Saba has written, sir, can you please start ophthalmology topic? So yes, ophthalmology we can start from Monday. Okay. One thing already I have told you, please remember it's very easy, and it's at 2 p.m. if you tell me to start any topic, it won't be easy because I have to prepare, I have to go through it at least one. So you put it on group at least a day before. I am giving you time, I am asking you. I have already provided all the details. Actually, I have informed you that what is expected, that if you prepare that topic beforehand, that will help you a lot. Just half an hour before or 1 hour before, if you are writing that, sir, can you go for this topic, then even if we start, then it may not help you because others might have not prepared, their mind is not prepared even if I start for it. So please see that already we have got very good open system. You can write it on WhatsApp, you can submit it, let everybody's opinion, let everybody understand that what you want. And there is nothing like that somebody is angry, somebody get angry, somebody is or at least I am not doing any kind of adverse remark on that. So if you do it, then it will be easy for everyone. Because otherwise all of a sudden somebody will start with something. Okay, it's fortunate that others have not woken up it. All of a sudden one will write ophthalmologist, please start, second will write, and that too on this chart when we are going for starting the class. Somebody will write, sir, please start rational pharmacology, some or pharmacotherapeutics. Some will ask, sir, start essential drugs. Some will ask for pediatrics. So please don't do this. We have got a very good system. I have told you, for everything, what's your difficulty, for everything, you can write. You try to write in very clear manner, so that even I can understand that what difficulty you people have got. This will help everybody. Even they should go through the topic, they should read it, and then they should try whether what's your difficulty. Somebody has asked whether it is there or not. So please do it, that will be helping. As per request, 2 students have requested for ECG. We'll rush through, there are so many slides, but we'll not go for each and a slide. We'll just make it in such a way that you will understand what's you require, because again in each case, example in ECG also, ECG is that way very big topic, and what exactly you want, that I should understand. Otherwise what I will teach you, maybe it is not useful, then we have wasted one whole class. So we should not do this. What we want exactly, we should be aware about. कल डॉक्टर के पास जाएंगे, मालूम ही नहीं हो रहा है पेट दुख रहा है कि सिर दुख रहा है कि पीठ दुख रही है, डॉक्टर कुछ तो भी दुख रहा है ना. व्हाट डॉक्टर विल डू, व्हाट डॉक्टर विल गो फॉर डायग्नोसिस. और तुम्हारे पास कल फार्मासिस्ट बनेंगे, यूएस में तुम में से कोई जाएंगे, और वो अगर आपको ठीक से नहीं बताएगा तो व्हाट एक्शन यू आर गोइंग टू टेक. सो ट्राई टू बी वेरी स्पेसिफिक, ट्राई टू बी क्लियर. Otherwise it becomes useless. Your time, my time, and it's not only 2 people, time of many people are wasted in that. So see that we are not doing it, see that we are trying to do it in better way. Already since last year we have maintained this, that whenever you ask difficulties, I try my best to solve it. So you put it everything and give me at some time. See, I am not God that I remember each and everything. And whenever you say I will produce in front of you, just like God produces, है ना, हवा में हाथ डाल के या बाबा जी निकलते हैं, वैसा I cannot do it. So please see that we are not doing it. Fortunately, I could do for ECG, but not always it may be possible. So please see, let us go fast. So ECG is what? Electrocardiography, people also call it as ECG. It is a voltage difference. It is recorded electrical activity of heart, because we know heart has got potential. That change in the potential is measured, and William Einthoven in 1924 it has started, and he worked a lot on that. He made various leads for that. So leads are various electrodes, positive charge, negative charge, and neutral. These are three basically. So there are three types up there. We call it as a bipolar. That is, there are two. One is positive end, second is negative end. There are three which are unipolar. That is, only one will be there. And there are 6 type of chase lead. So total there are 12 leads are available. The most popular one, or which you people are, which is easy to understand, is lead 2. We call it as okay. So limb lead 2 is more popular. Limb here, it means hand and leg both. So it is foreleg and forelimb and hind limb both, if we consider. So these are total 12 leads are there, and most of the latest machines are advanced. They are having continuous data of all these 12 leads simultaneously. So these 12 leads are taken, and accordingly we get so many graphs simultaneously. So these are the limb leads. These are the single load, or we call it as unipolar one. So that is AVL, AVR, R is right, L is left, and one is F for foot, and N is for neutral. So these are various, only I told you one neutral, and this is a unipolar. Then these are the bipolar. So these are I'll make it better. So these are the limb leads, where both limb leads are there. Limb 1 only, both hands are there. Limb 2, right hand left leg is there. Limb 3, left hand left leg is there. And this AVR, AVL, AVF, they are generating. These are different conduction places on that way. So these are singular one. So how these are placed? These are called as chest leads. These are single lead or unipolar lead. So this is V1 red, then V2, V3, V4, V5, V6. These are the places where it is there, and we call it as a the first place is there angle, that is called as the angle of Lewis, just below sternum, or somewhere around second rib. Then midline, that is clavicular line is there, and V1 is towards right side, and other three are there in the left side, and how they are positioned. So these are all anatomical positions which are known. What they are recording: V1 recording around this right atrioventricular area, just near junction. V2 is somewhere around AV node. V3 is V3, V4 both are this bundle of his. V5 Purkinje fiber, and V6 the ventricular muscles or ventricular myocardium. So these are showing various limbs again. One AVR, V1, V4, they are having anterior one. Then 2 AVL, V2, V5, they are showing septal areas, that is septal wall. Then 3 AVF, V3, V6, they are showing the inferior, and the inferior is 2 and 3rd. Lateral 1, AVL shows V5, V6. So these are various areas these are covering, and because of that it covers maximum area. These are mentioned with the colors also. So these colors will show accordingly. This green color, posterior wall color, inferior wall color. So these are various colors they show, and accordingly the heart areas are covered, and therefore this cover maximum area. This is very famous, as we have seen that the first scientist was Einthoven, and this Einthoven's triangle is there that makes various leads. So right arm to left arm is lead 1, right arm to left leg is lead 2, and this is lead 3. So on that basis these leads are there, and they are recording various activities. So total all leads, how they are making this activity. If you take heart in the center, then at various places, tooth, then 1, 2, 3 and these are unipolar, so they are showing the current flowing in what directions. So these are showing current at different direction, and 2 covers maximum what we can say anterior side and left side of left ventricular. So most of time 2 becomes easy, lead 2 is usually used. This is normal graph paper which is there, and it shows this has got this kind of boxes are there, large and small boxes. One large box represented 0.2 seconds and the small represent 0.04 seconds, that is 40 milliseconds of time, and it shows 1 millimeter of amplitude. This amplitude here, the large shows around 5 mm of amplitude. So this is the amplitude in ECG. Here approximately 10 millimeter is equal to 1 millivolt, that is the current. So this is the reference current is passed, and accordingly we measure the potential now on that basis. So amplitude shows 10 millimeter is equal to 1 millivolt. So the minimum is how much then? It is 1 mm is there. So 1 mm is 0.1 mm, 0.1 millivolt it is showing. So this is ECG paper on which it is recorded. The speed is maintained around 25 millimeter per second. So on that basis 25 millimeters are going per second, and on that basis these manual calculations were made. One large is equal to 5 mm is equal to 5 mm by 5 mm box, that represents 0.2 seconds, that is 200 milliseconds time, and 0.5 millivolt amplitude. Okay, and one small block represents 40 millisecond time and 0.1 millivolt amplitude. We have just calculated above. Then this is a very common one. This is we call as a lead 2 ECG. So we can see very commonly it is there, that is P wave, then Q wave slightly go down, then R wave goes up, S wave again goes down. From that then S is again plane. This is the what we can say baseline. So baseline, then P gets slightly upward, again baseline, Q goes down, then very big upside, big voltage change, then comes down back, again goes to baseline, and then there is a T wave. Now on that basis we have got various situations. First is from the beginning of P to the beginning of this Q, almost we call it as a PR interval. Then from the end of P to beginning of Q, we call it as a, or beginning of R rather, we call it as a, in the middle of PR segment. So PR interval, in that its P starts from beginning, and in segment it start after that. Then very important is we call it as a QRS complex. So this is what QRS complex. So this QRS complex, next is the ST segment. If you remember, in myocardial infarction we have seen that it causes elevation, that is instead of this level it goes up. Then this is called as a, from the beginning of that to end of T, we call it as a QT interval. So these are very common things which are related to ECG. So these are things are called as a PQ, PR interval, PR segment, QRS complex, then ST segment, and QT interval. So these are very, very important. One more thing is there, that is called as a RR interval, that is one peak, the highest top of this is R. So R to next R, what is the difference or what is the distance into it, that we call it as a RR interval. Then next in this is, these are the timings, how much actually they are. So PR is around 0.12 to 2.20 second. Then the QRS is less than 0.10 second. QT interval is 0.35 to 0.45 seconds. Okay, these are various normal figures. Now let us make it with ECG. We know, let us make this ECG with what we can say actual cardiac cycle, what it happens with. So this cardiac cycle, so it shows, we know that the conduction impulse of the light current passes from SA node to AV node, AC node, then to this bundle of his Purkinje fibers and this myocardium it goes to. So let us see one by one what happens. So initially this is atrial depolarization, that is Q, that is P wave, slightly up side current passes, then it slowly reaches to this myocardium, and then there is a myocardial contraction, that is QRS. Particularly R is for ventricular depolarization, T is for ventricular repolarization, and these are the time in between, that is passing current from that one area. Now we shall see actual events and what happens with that. So first is SA node generates impulse. And this start with SA node, it generates impulse. As soon as it generates impulse, so it will cause atrial contraction or systole of atrias. So we will get P wave. So it is there, it has reached to whole atria, so we have completed complete P wave. So that is atrial systole and P wave are matching, or P wave is because of the atrial systole. Then impulse passes to heart apex, that is from that it goes to AV node, from that it has passed through bundle of his and it has passed to Purkinje fiber, so it is going over there, it has reached up to that area, so it has just started. Okay, so then when it reaches to Purkinje fibers and whole ventricle, then it causes completion of ventricular systole, that is, and this QRS represents ventricular systole. Then we know what is innervations are there. Heart is stimulated by sympathetic cardiac acceleratory center, heart is inhibited by parasympathetic. Now you know about it. So accordingly this stimulation will cause increase in the sympathetic activity or parasympathetic activity. Sympathetic is stimulant, parasympathetic is inhibitory in nature. So what is cardiac cycle? We know systole, we know diastole, then we know what is ventricular feeling that takes place. Okay, then heart blood pressure is low as blood enters into atria and flows into ventricle. AV walls are open till that period, ventricular systole, then atria relaxes, that is we call it as atrial diastole, and then there will be ventricular pressure will be increasing. If you remember, I told about Frank-Starling law during angina, so it causes pressure on that. This AV walls, atrioventricular wall will close, isovolumetric contraction takes place because volume is same, now heart has filled and all walls are closed, and then it will cause opening of the semilunar wall and there will be ejection of blood from that. So isovolumetric relaxation is in the early diastole, ventricular relax, then backflow of the blood in aorta is prevented because of that semilunar wall, and there is a dicrotic notch, that is brief rise in the aortic pressure which is caused by the backflow of the blood rebounding off, and this is responsible for sound, if you remember in physiology. So again this is how we make it with ECG, cardiac cycle, and all timings we can make. What is the pressure that is maintained, volume, what is happening. This is very good figure to explain. You know, each cardiac cycle is for 0.8 seconds. Okay, what happens during that? If we take with the time, if we start with that from SA node, the current passes. With that, there is a P wave is there when atria is contracted, or and atrial systole is there, then slowly it passes through AV. This is that when it passes through AV, then Q starts and it causes contraction of whole ventricles, that is for around 0.3 seconds, 0.4 seconds, and then this causes this ventricular systole. From that it comes down, and then there is a relaxation of the ventricular diastole. So these are various sounds. When this diastole is there, this is at dichrotic notch, there is a one sound, and during atrial wall closure sound is there, we call it as lub dub sounds are there. Then pressure that changes into it, accordingly the changes are there. Okay, internal pressure changes, and this volumes are changes, ventricular volume. So these are changes will taking place, and accordingly walls are opening and closing. So this is very good figure, you can match with that. So this cardiac cycle are there, one by another this cardiac cycle are there. We already matched it with the figure, that how it takes place. If we go for that ventricular filling and ventricular that is atrial contraction, isovolumetric contraction, ventricular ejection, isovolumetric relaxation, and ventricular filling. So these are various steps which are happening during cardiac cycle, which causes opening closing of various walls, and accordingly there are changes in the pressure. We'll now move towards ECG slowly. And there are sounds are there, that is lub dub sound, which is because of the closing of various heart valve, that already I told you. So these sounds are there that appears. Now this is ECG, which is normal. The second one is there, where you can see somewhat enlarged one, but you'll find that the ST is slightly upside and the rate is comparatively faster. P is almost diminished in that. So these are the abnormalities which are there. We shall see one by one what are these. Then the C1, we can see that there is no clear identification of PQ RS, and there are so many. These are what we call as arrhythmias, because these ECGs are not clear ECGs. Okay, so the heart is not giving any time for this atrial or ventricular contractions, or the impulses are too many, and therefore this kind of wavy pattern is there, which is very haphazard, very abnormal pattern is there. Now this is how we are having, as we have seen how it is with P. This start with P, then QRS is for this ventricular, and T wave is a recovery wave for our relaxation of ventricle. Then yes, we cannot see the atrial relaxation wave as we see T wave. Because why? Because there is a very powerful wave of ventricular contraction is there, so we cannot see this. Or maybe it is slight downward deflection, but we cannot see the recovery wave related to atrial diastole, but we can see ventricular systole and ventricular diastole. QRS is a ventricular systole, T wave is a ventricular diastole. So this is how we get, these are how ECGs are there. So isoelectrical line we will see one by one. P wave, we have seen that it represents atrial contraction, and when full atrial contraction is there, that P wave is there. The depolarization slow within the AV node, there is a brief delay or pause before the depolarization conducted to the ventricles. Normal duration is 0.12 seconds. The P wave is absent in what condition? Atrial fibrillation, SA block, and the AV rhythm, if it is not proper one, it is there. The peak P wave is there in atrial hypertrophy, when heart is not or there is a heart failure situation, and atria has got hypertrophy. In that case, the P wave is more comparatively, or its size increases. I'll repeat this. If you can see here, you cannot identify clear P wave. Okay, or there are what is P, what is Q, what is T. You may slightly say that the bigger one are maybe QRS, but again P are also bigger one. So this type of abnormal figures can be seen. This is how P wave are there. Then PR interval is normally 0.12 to 0.2 seconds. It is prolonged in the heart block when the conduction is slow. It is decreased in the old Parkinsonism White syndrome, WPW we call, where there is a atrial tachycardia. So in that there is a shortening of it. It is faster currents. Then QRS complex, it represents the electrical activity of both ventricles. Ventricular depolarization, that is ventricular contraction, we can see with this. Q wave, R wave, S wave, these three waves are there, bigger waves are there. Normal QR duration is 0.12 seconds. So Q wave starts with the bundle of his when it is going down. So this comes down. So in that QRS complex, we get slightly lesser one Q is, because it is coming towards that. Then slowly increase in there because it is going for whole ventricle, or it is going through the Purkinje fibers. Then in both side it is reaching slowly downward deflection, it is coming, and full contraction it has already caused. So it is going down and then it is coming out. So as I told you, it is around 0.04 second there. R wave is there, the first upward deflection, it comes after that, after going down, and it is responsible for early ventricular depolarization. That is, what's your repolarization has taken place or contraction was there, now it is coming back or it is going for diastole. So this is the sign with R wave. So this QRS complex we have already seen with this. Yes, 1, 2, 3, 4. So these are the signs which we have got. These are the lead to situation where we have got QRS complex. Then S wave is there, which shows late ventricular depolarization, and slowly it comes down with that. Large QRS indicates ventricular hypertrophy, because in that ventricular it is taking more time to cross the current. So because of that ventricular hypertrophy, the current is sufficiently, it is not going. So it is indication of heart failure. ST segment is another important one. We have seen ST segment in myocardial infarction, angina, etc. It is the plateau phase of ventricular repolarization. It is isoelectric or slightly upward T wave is there. If the ST segment is elevated or depressed beyond the normal baseline, it is sign of serious myocardial infarction or myocardial pathology, it is there. T wave is representing the rapid phase of ventricular repolarization. Okay. So it is going for this. After depolarization, there is, if you remember, the ion sodium potassium pump is sodium potassium ATPase is working. So this is working. It will be peak T wave in the early myocardial infarction, and because of T wave is go up, because along with that ST segment will also go up. We will call it as a ST elevation. In case of hyperkalemia also T wave can be increased. There in some black races it can have somewhat more bigger T wave than other people. It can be inverted in MI, that is we call it as a NSTMI, that is non-STEMI or no ST elevated myocardia, in where T wave is inverted. Ventricular hypertrophy is there. In that T wave can be inverted. In hypokalemia and digoxin treatment, this T wave can be inverted. Then next is QT interval, that is from, it starts from the Q to beginning of Q to end of T. We call it is 0.4 second when the heart rate is 70. It is prolonged in the hypocalcemia and hypomagnesia. That means it causes increase in the length of it, and if it is prolonged, that means heart rate is less in these people. U wave is very small, it is not noticeable, and it is repolarization of interventricular septum. It is very low amplitude, but it can become prominent when there is a hypokalemia or hypercalcemia or hyperthyroidism. In that Immediately after T wave, U wave can be seen. In very less people it is there. As I told you, it is not prominent, it is not significant, it is not appearing, but it can be there when there is a hypokalemia or hypercalcemia. Then there is one more wave is there, J wave can be seen. That is represent the approximate end of depolarization and the beginning of repolarization. It shows camel hump like situation. It is after this QRS and before T, just before start of ST elevation, it can be seen, and it is a sign of hypothermia and hypocalcemia. Low voltage ECGs are there, the ECG voltage will be down, whatsoever line is there, that will be going down. Maybe it will look like a normal one, but the potential will be lesser. The potential which is observed, we have seen that for each for 10 this one lines, it gives 1 MV, 1 millivolt voltage is there. So if it is it will be getting less millivoltage in obesity, and then emphysema, COPD and severe hypothyroidism. In that ECG will be there. Normal heart rate is around 60 to 100 minutes. Less than 60 we call it as a bradycardia. More than 100 we call it as a tachycardia. So how we can measure with ECG? So I told this is based on RR interval, I told you. Okay. So R is there, you start counting number of peaks in a given time. We know, we have seen the timing also here on this graph paper, that how much these big lines are measuring for. So basically from this to this is 0.1, 0.8 milliseconds, 0.8 seconds. So on that basis we can have timings, and from this to this how much time it is taking, we call it as, so this is, we call it as RR intervals. Okay. So we calculate this, we will understand that how much it is, and then if it is more than that, we can call it as a tachycardia or bradycardia. So number of large box between R to R, how many are there? 300 divided by this, or if it are small box, you are measuring that number of small box between R to R, that is we call it as a RR interval. So these are the RR intervals. They are very useful, important for measuring the heart rate. So these are, see, this R to this R, this R to this R. So what is the R to R interval? We have got so many, these all machines, they are automatically computed, calculated. Rhythm, look for the distance between identical waves. Most commonly used is RR, as I told you. So on that basis of RR, it gives, these are the automatic machines are there which are calculating it. It is also measuring BP simultaneously. So BP is 110 to 68 or 100 to 67, like that, and these are giving at various rates, at various speeds it is giving, and this indicates the changes into ECGs. Axis, any point during depolarization, repolarization of electrical potential are propagated in different direction, and most of these cancel each other out and only net force is recorded. This is called as a axis or cardiac vector. Example we have seen earlier. This is how current are passing through various. So type 2 is measuring from this side. So whatsoever current is coming towards this is recorded, and if any current which is going opposite to that, that will also be recorded, and they will nullify each other. As we have seen that we do not able to see in type 2 I am speaking about, it is not measuring, or it is not able to measure the atrial depolarization. It measures ventricular depolarization but cannot measure atrial depolarization. Why? Repolarization, I am sorry, it cannot measure atrial repolarization or atrial diastole. Why? Because again this current is nullified. So these are various ways, these are various points. If you take it as a circular picture, and these are the instrument, so this is taken from this direction, this is taking from this direction, 2 is taking from this direction, AVR is taking from this upper direction, AVL is from this side left direction, 1 is taking from this. So this gives idea from all side what is happening to the current. If any area who is affected particularly, then that area is identified, that where the current is problem, and that can be taken into. So how to check access QRS in lead? One will be same in lead AVF, it's like that, they are equal, that means yes. So we call it as a two thumbs up signs, and it is the normal axis. So these are various axes, will not go into this much details. Composite 12 lead ECG output from one lead recorder. So these are various leads simultaneously, 1, 2, 3, AVR, AVL, V1, V2, V3, V4, V5, V6. So these are all simultaneously it is giving, that is called as a 12 lead ECG. Nowadays, as I told you, these are electronic, and accordingly we get like this from all sides. You will find that same one lead, it is reverted or inverted one, because the lead direction changes. Again in V1 it is the direction has changed. Okay. So these are being a different side, different one, we can see a different kind of potentials for different one, and this gives us idea how it is working, how it is happening. So on that basis, it also calculate this electronic machine. Nothing is manual nowadays. They calculate the heart rate, they calculate various things, because it is stored, information is there, it matches with the normal and abnormal which are stored into these machines, and they can put this, the whatsoever observations onto it, that this shows this kind of observations. So these are how ECGs are, will not go into this. See, this is a ST elevation. Okay, this is normal ECG, and see this ST segment, this is the line PQ, then this ST line is almost same, this is the normal ECG. Here PQ line is there, Q is going down in next one, but S is increasing, T wave is also peak. So this is called as a ST elevation. Immediately it will be like that, then after some time it can become like this. There is R, but Q is almost absence, and S and T, sorry, Q is there, R is there, S is almost absent, because S and T has got merged to each other. This is what we call as a ST elevation. So in next few days we can say that Q wave changes, that Q wave become bigger, and R will be almost gone or nearly gone. Here all no R wave is there, and Q is totally inverted or is enlarged. ST may be now at baseline, and T wave is inverted here. Here also T wave is inverted. Then after several weeks this can happen, that some R may return. T wave is become less inverted, and Q becomes shortened, which was too much earlier. So these are the significant changes which are occurring in the myocardial infarction. I will not go for this. I will not go for this. Okay. So these are the changes which are occurring. We can see some of the arrhythmia ECG changes that will help you to understand in better way. See, very simply I am using this arrhythmias, how they can be obtained, how they that can be seen. uh, I'll just see, these are various arrhythmias. We can see some images so that it will help you to understand in arrhythmias. I'll share this slide with you, particularly in arrhythmias how it is. So this is on the basis of the heart rate is calculated around 70. See, this is RR interval, 1 hour to the second hour. So in 300, 1, 2, 3, 4 are there. So it is around 75 this one beats per minute. So the big boxes, in that it is easiest to memorize the table, rule of 300. That is, number of big boxes is 1, then it is 300. If it is 2, then rate is 150. If there are 3, then rate is 100, heart rate is 100. If there are 4 in these big boxes, then 75. And if 5 big boxes are there, then the rate is 60, and likewise. So this is heart rhythm. Now you can see there is a big gap between this. There are 2 are continuous, and then there is a big gap. This was a normal one. Okay, so we call it as a type 1 type of block. This is another is a type 2 block, complication of inferior myocardial infarction. You can see ST elevation over here, and at the same time there is a sort of arrhythmia, because one rhythm is there, then there is a gap, then there are 3 beats, again there is a gap. So these are a typical pattern which is there. So this is common ECG. We have already seen normal sinus reason and what are their timing for each, what is PQRS timings are there. So sinus bradycardia shows heart rate 60, and it is far away. Every ECG otherwise looks same, but the distance between 2 R is, so rhythm is regular here. Why rhythm is regular? Because ECG is normal. Otherwise, only difference between R to R, that has changed. Okay, and therefore the heart rate is less than 60. We call it as a sinus bradycardia, and therefore the timing has been more slightly increased. Sinus tachycardia, see now the difference in these 2 figures. In given time, if that number of blocks are there, how many you can find? So there are only 4. Okay, so it is less than 60. Now there are so many, 1, 2, 3, 4. So heart rate is more than 100. Okay, QRS may be looking, rhythm is again here that way regular, everything is there, but the this P wave is there, but this rate has increased. Then sinus arrhythmia is there. You can see rhythm is irregular, heart rate is variable. Okay, rhythm is irregular. Why rhythm is irregular? You can see these three, they are regular. Then these are irregular. The distance you can see. Okay, so this is during inspiration it is regular, during expiration it is irregular. We call it as a loss of sinus rhythm. Okay, there is a problem with the sinus rhythm. Then premature atrial contractions, you can see almost inverted P waves. Okay, and rhythm is there, P wave are premature and abnormal, heart rate is not clear. Then rhythm is also irregular because PQRS, when PQRS is in normal, this one we got is a, we'll call it as a normal rhythm. Atrial fibrillations, you can see so many beats around P. So rhythm is irregular. P wave is wavy and irregular. Why? Because atria, P wave is responsible for atrial conduction. Means whatsoever atrial conduction is there, impulse conduction, that is measured in form of P wave. So here you can see many things with the P wave, so many small P waves, then normal Q, normal R, normal S, then again T is almost normal, and thereafter again wavy pattern of P wave. So that shows the atrial fibrillation. Atrial flutter, again this atrial contraction is around 250 to 400, ventricular is variable, and therefore we call it as atrial flutter. So QRS is almost same, but T and P are mixed with like that. It is called as a sawtooth, means too many waves are there. जो लकड़ी काटने की सॉ आती है ना, उसके जैसे सॉ के टूथ जैसे वो दिखते हैं, that is called as a sawtooth one, that shows atrial fibrillation. Then what happens in the premature ventricular contractions? The heart rhythm is again variable, heart rate is variable, rhythm is irregular, and no P waves are associated with the premature beat. And even you can see that there are changes in the QRS, some Q are big, some are less, some are near. Okay, so this type of you will see these changes will be in premature ventricular. So ventricular rhythm is there, you can see how changes are there. This P, Q is there, from that Q is, R is okay, and AS has gone down like this. Somewhere all of a sudden this will be happening. This is again normal, all of a sudden one will be okay. So this type of is there in the ventricular arrhythmias. Again there are changes in the ventricular arrhythmias. Their heart rate is 100 to 250. Somewhere it is rhythm looks regular, that is one after another, there is no abnormalities, but no P waves are there for corresponding, because they are dominated by QRS complex. And even T wave you may not able to see, it is almost merged with that. You can see that sort of ST elevation like that. So no PR interval you can see. QRS will be there only, that will be easily visible. So these are the changes which are there. Ventricular fibrillation, you can see this. You may not able to think that what kind of wave it is. It doesn't look like ECG. So we call it as a heart rate is 0, because too much heart rate is there and we cannot measure it. The machine will show it as a 0. Rhythm is chaotic, because when beats are happening or going, we do not know. P waves are not appearing at all, so therefore no PR interval. And QRS is again you cannot measure, because you cannot able to identify that what kind of wave it is there. So this is severe ventricular fibrillation, and this is the straight line, red line, we call it as a no heart rate, no rhythm, no P wave, no PR interval, no QRS, and that can be a diagnosis. We call it as a sudden cardiac arrest. So because of this sudden cardiac arrest, you can one can try for this cardiopulmonary resuscitation, and with this resuscitation, if something can start, this is something like shown in movies. Doctor starts something or gives electrical current, and then the beep starts. The beep was flat, so this is a flat ECG, and then it can start with that. When there is a first degree heart block, then you can see the heart rate is normal, rhythm is normal, but before each QRS there is slight change in this P wave. Okay, so that shows first degree heart block. Then other type of heart blocks are there, like Mobis type or Wenkebach type of there, where rhythm is irregular, heart rate normal, it can be slower than normal, PR interval will be longer because of that. Then heart rate in this other heart, will not go for each and every type of heart block because we are not there. So these are what various ECGs are there, and these are showing various examples. It is a premature ventricular, or we call it as a PVCs, premature ventricular complexes, and in that this type of situations are there. This particular very clear sign PVC is there, already marked with arrow over here. So these are various situations which can be there, which indicates various ECGs. I'll share this. Not all are important. These are for basically medical students, but this will help you to understand various situations. So I hope you have understood the things. If you have any difficulty, you can ask. Sessional syllabus, Sabha, you decide, you put it on group. Already we discussed it earlier, long back. We have made it almost clear, but you try to divide it in 3 equal portions. One is covering general pharmacology and other topics. Then second will be related to various systems, and then you make it. Okay, you all decide, you have your internal discussion, and then you finalize the syllabus for the pharmacology for first sessional, or rather all 3 sessional examination you all can decide. Okay, if you have any difficulty, you can put out there. Try to make it equal, otherwise it will happen that you may feel that now it is lesser, but then topics can be too much details, and then it will be difficult for second or third sessional. Because anyway you have to attend at least 2 sessionals. It is always good to appear for all sessionals, but minimum 2 sessional you have to attend, and then it should not happen that when you feel that it is syllabus is less, but if some questions you may not able to attend, then your next sessionals can be a problem. So be sure you are trying it, and then take care about it.